So welcome. My name is Ferrari Emiliano, and I'm from Bologna. I work as a surgeon and prosthodontist, and I'm so happy today to be here to share with you my daily practice. For that, I want to thank Rain83 and Dimitri from Medipex for the opportunity. I hope we will spend together a fruitfully hour talking about implant rehabilitation. The idea is to give my lecture for about 40-45 minutes, and after that we have all the time of the world for your question and the answer. I know that are connected with us, as you know, Gianni Storni for the technical answer, and also my technician Emanuele Giunchi. So if you have some question for the technical parts, for sure we have all the answer for you. The idea I saw is to give my lecture, and after that feel free to give me all the answer that you want. The lecture is done by two parts. First of all, we will talk about the theoretical concept about OT bridge, and after that we will see some clinical cases, 4 clinical cases for different situations that we have solved with the same solution. And the solution is called OT bridge. Rain83 is a factory known all over the world because of its abutment for removable prosthesis. The sphere is worldwide accepted as the most common and most used kind of abutment for removable prosthesis. But today's story starts with the introduction of a low-profile attachment. The name of this low-profile attachment is OT equator, and from the OT equator, we can show you how to use it for removable and fixed prosthesis. Okay. So let's share the lecture. Okay. So everything starts with what we call the evolution of the sphere. So the creation of an abutment with the same function and the same structure of the sphere, with the same retentive area of the sphere, but saving a lot of prosthetic space. Because you know that the sphere maybe is today the best attachment for removable prosthesis, because can help you in give you retention, also in very important divergency. The only problem that we check during the time about the sphere is sometimes the dimension. So the question was if it was possible to have an attachment with the same performance, but saving some space, because you know that in prosthesis, space is the most important thing. The answer at this question is the OT equator. OT equator is those kind of attachment that nowadays we used with the same performance of the sphere, but saving the space. But the real new concept connected with the equator is that the equator is threaded inside. So you can use it not only for the direct retention of removable prosthesis, but you can also use it to screw something on the head of the equator. So first of all, we have screw some bar that was called OT bar. And after that, nowadays, we use it also to go for fixed prosthesis. But what's the concept related to the fixed prosthesis about the equator? Okay, starting talking about multi-unit abutment. Everybody of you know what multi-unit abutment are. They are intermediate abutment that you need to build screw rehabilitation on implant, specifically when you use internal connection. Because you know that if you want to screw some rehabilitation on implant, you need really straight implant, parallel implant. Because literature told us that if you have divergence upper than 22 degrees, it's really difficult to have perfect seal all around the implant platform in implant with internal connection. So the only way that you have to give a correct seal is use an intermediate abutment. But the function of multi-unit abutment are two. The first is the displacement of the prosthetic connection outside the gum. And the reason is to relieve our patient from the pain during the try that you have to do during the rehabilitation. You know that it's easier to work on a implant platform outside the gum, respect to work when it's in a deep space of gingiva. The second function is the correction of this parallelism, the correction of divergency. Because as I told you before, sometimes nowadays we go with rehabilitation with a few number of implants, and the most distal implant usually are placed divergent respect the frontal implant. So we have to manage some divergency between implant, and we need something to accommodate the implant platform. But you know that multi-unit abutment are two kinds, straight one and angulated one. Straight one are made by one piece, angulated one are made by two pieces. And the problem are related with the angulated one, because sometimes it's a little bit complicated, the use of this kind of abutment, specifically in the distal portion of the mouth. And we have also other problem related with angulated multi-unit abutment, problem connected with biology and connected with the aesthetic because of the dimension. So the idea is to use always straight multi-unit abutment. From here was born the concept of OT bridge. So use the OT equator as a straight multi-unit abutment to avoid all the problem connected with the use of the angulated multi-unit abutment. But the only way to do that is to change the abutment that have to couple with the OT equator. Because you know that when you project your rehabilitation, you have to check one axis of insertion. And all the abutment that are parallel with your axis of insertion for sure have no problem. All the implant and abutment that are divergent respect the axis of insertion can give you some problem during insertion. So the secret was to change the shape of the abutment that you have to couple with the equator. And the innovation is those abutment that it's called extra grade abutment, an abutment with an extra space to consent you the use of those abutment also in implant divergence. So the portion that you see signed in red in the picture is the extra grade. And you only have to couple this portion of the abutment in the direction of the divergency of the implant. But for sure, if you want to have the perfect coupling of these two kind of abutment, you need a space, okay? You need a tolerance. And the real secret is what fill this tolerance. And what fill this tolerance is something that it's called Seeger. The Seeger is that white ring that you saw in the animation that work to fill the tolerance between the equator and the exograde abutment. What is a Seeger? Seeger is not a concept that came from Ray 83, and is not a concept that came from dental world. It's something that came from mechanics. Because the definition is that is an incomplete circumference elastic steel stop ring used as a fixing element because of its ability to deform himself in a state of tension. It means that you can use it as a fixing stop ring when you have to couple two structures. In mechanic, usually those Seeger are made by metal. But in our case, Seeger is a little ring in acetylene. But why you have to use OT equator and not multi-unit abutment? Because all implant brands that for sure you use are provided of a multi-unit abutment. So if you have to change your multi-unit abutment for the OT equator, maybe you need a reason to do that. We think that there's a lot of benefits related with these systematics. Benefit in mechanic, biological benefit, aesthetical benefits, and of course, benefits related with the organization of your daily practice. So let's see all the benefit that we found in this for this solution. Let's share this benefit, and if you found something that interests you, maybe this is the solution. First, the benefits are mechanical benefits, and first of all, they are related with the bigger diameter of the screw. Equator screw is bigger, 30% bigger, respect the usual screw for a multi-unit abutment. And it's easy to understand that the bigger screw means a stronger screw. So you can avoid the problem of the broken screw sometimes. The second advantages is related to the absence of those part of thin ring and the partial fillet that are related with the presence of a second screw, because angulated abutment need a secondary screw to be connected with the implant, and that screw need a space, and this space create a thin portion of the ring that can break easily. The last mechanical advantages is the one that I told you before. So you can use it easily to correct divergency between implant because of the morphology of the exograde abutment. The biological benefit are first of all connected with the concept of one abutment at one time. You know that all the abutment manipulation give us a soft tissue downgrowth and a bone loss, also without inflammation. And that is due from the fact that when you screw something on the head of your implant, you have the creation of a junction, junctional epithelium. This junctional epithelium is forming during the flap healing and give you a protection, a barrier from the bacteria to go inside the suture. So if you can use your abutment and never unscrew it, you can avoid the violation of this junctional epithelium, and you can maintain your biological seal. During the lecture, I will show you when we will have our clinical cases. I will show you how to use this abutment from the first day of the surgery to the last day of the delivery of the rehabilitation, always without unscrew the abutment. So saving this biological seal. The second benefit related with the biology is that the screw thread is not in communication with the internal part of the implant. Because in the angulated abutment, you have the secondary screw that, of course, is a door for the bacteria to go inside the implant. Using a one-piece straight multi-unit abutment like the OT equator, you can avoid this problem. The second category of advantages are, so I say biological advantages. And the very important things is that you can maintain the biological seal. As I told you before, I will show you how to use this abutment from the day of the surgery to the end of the treatment. But sometimes you don't want to go for immediate loading or for the immediate use of your abutment. So what you can do, the important thing is to screw the abutment on the head of the implant the day of the first surgery or the day of the second surgery. And if you don't want to use it at the first day, you can use this kind of protection that save your flap and, of course, save the biological seal in the apical part of your attachment. The third family of advantages are the aesthetic advantages. First of all, you have to consider that sometimes implants in the anterior portion of the maxilla are tilted because of the shape of the bone. So you have to use angulated abutment. But the shorted angulated abutment of 30 degrees is 4 millimeter high. So if you don't have 4 millimeter tunnel of gum in the frontal zone, you can have the risk to show the metal part of your multi-unit abutment. OT equator is available in a lot of high, and it starts from 0.5 millimeter for internal connection implant. So you can understand that 0.5 millimeter high save a lot of space and give you the opportunity to have the abutment inside the gum, to doesn't show it during the smiling of the patient. The second aesthetic advantages is related with the possibility to use it in a blind way. What does it mean? It means that the retention of this attachment is not due only to the screw, like in the multi-unit abutment, but is due to the presence of the seagull. So sometimes you can use it also without the screw. Not in all the implant, because of course, if you don't put your screw, it becomes a removable prosthesis. But we think that in 25% of the abutment that you use, you have the possibility to use it in a blind way. So maybe you can check the worth emergency of a screw, the worth position of a hole, and use it in a blind way. So maybe in 4 implant rehabilitation, you can use just 3 screw. Maybe in a 6 implant rehabilitation, you can use 4 screw. Okay, so the use of this kind of abutment in a blind way can save you some aesthetical problem. The last family of advantages are related with the organization of your daily practice. I think that it's a really interesting benefit that the question that you can use it a single connection for fixed and removable prosthesis. So in the same treatment plane, you can have maybe a provisional removable prosthesis retained by OT equator, directly retained by OT equator. And the final rehabilitation maybe can be fixed and at the same time retained by the same equator. So single connection for fixed and removable prosthesis means easy way to plan your treatment. Second reason is that you have the same components for each implant platform. It means that if you have two or more different brand of implant, if you don't use OT equator, you need two or more kind of components. One component for each implant platform. But if you use the OT equator, you can have maybe some whole implant places from other dentists, and you can maybe put some more implant of the brand that you prefer, and go with the final rehabilitation with the same components. So it's very, very easy, okay? It's very, very easy and can save money and time. The last reason is that OT equator is also available for unknown implants. And you know that nowadays, with the worldwide diffusion of implant therapy, can happen to meet some unknown implant in our daily practice. And now I know how to treat that. But a few years ago, for me, was really big problem to go with fixed rehabilitation on unknown implant. So this short introduction just to explain you potentiality of OT equator and OT bridge. Now I will share with you some clinical cases with the use of this OT equator on unknown implant, on a different brand of implant, for immediate loading and also for delayed loading. First clinical case is an OT bridge delayed loading. It's the case of a patient that came to my office in this situation with removable denture retained by two attachments on two implants that I didn't put, so not my patients. The situation is a stable situation, but patients need something more. She wants fixed rehabilitation. In this case, I don't need to go with immediate loading because the patient is happy with the retention of the denture. So I don't want to take myself the risk of immediate loading, because you know that nowadays immediate loading is a concept really accepted and it works very well. But of course, immediate loading give the clinician little more risk of unsuccess. So if I don't need to go with immediate loading, I prefer not to go. For that reason, the treatment plan was to put two more implants in the anterior zone, waiting 2 months for the healing, and the day of the healing, during the second surgery, the uncovering surgery of the frontal implant, to use the OT equator. At the same day, customized OT equator for the other implants that are not my brand of implant. So, as I told you in the introduction, here we have two different brands of implant, but the same prosthetical connection. From this point to the end of the treatment, we can avoid all the mistake related with the management of different brand prosthetic connection. Starting from here, we work just in only platform, that is the OT equator platform. This case is treated with an analogic kind of impression, and that's the way I use it to take the impression. So customized transfer. You have a transfer dedicated for OT equator, different kind of transfer dedicated to OT equator. You have snap-on transfer and you have screw transfer. On this case, I choose screw transfer, customized by my clinician. the customization is done to avoid a big quantity of impression material. Of course, you have to use it with a customized impression tray with hole to arrive to the screw. And on that way, I'm sure that I need less impression material. And you know that less impression material means less contraction and better results. So that's the way I take the impression in delayed loading treatment plane. During the same appointment, I take a second impression with a duplicate of the whole denture of the patient. This duplicate is used to check the relationship between the inter-arch relationship, so the relationship between upper and lower jaw. I just used to fix the two implants, in this case the frontal implant, with the template, and on that way I have a perfect relationship, hold relationship, the one that patient have in whole denture. I can duplicate it for my new rehabilitation. So I use the template on the master model to do the articulation. And now I'm ready to go for the final rehabilitation. First of all, tooth assembly, so the waxing, with what I go in the mouth, and in the same appointment, I do two different things. First things is to check the precision of my impression. And to check the precision, I use this count of acrylic contour key. It's an evolution of the customized transfer, just blocked all together. And I'm sure that if this acrylic contour key perfectly fit on the model and perfectly fit in mouth, I'm sure that the impression is good. Okay, so you go in mouth with this acrylic contour key, you do your check, and if the check is good, big part of the work is done, because now you are sure that your master model is perfect. During the same appointment, I go with the check of the wax, so the waxing test, to check aesthetics and phonetics. In this case, you can use your OT equator abutment to give retention at this waxing test. Just putting inside the waxing test two female of the attachment, and you can have a stable situation for your aesthetic and phonetic test. When you are happy about the aesthetic and you are happy about everything, you know that this is the final results that you want. So now you have two information. You are sure that the impression is good, and you know that this is all the prosthetical space that you have. So inside this prosthetical space, you have to put everything you need for your rehabilitation. In this case, my technician went in CAD/CAM way for the rehabilitation of the bar. So first of all, the scan of the volume, and these are the volume that we have checked in the mouth, and inside those volume, we can project the bar. The important thing is the thickness check. So on that way, we can check the position of the bar and the space that we have to put the retention parts for the final rehabilitation. So on that way, we have a view of all the space that we have to project our bar. This is the final project of the bar, and this bar is milled. Okay, so Sheffield check on the model of the milled structure to be sure of the results of the CAM work, and after that a little particular of the extra grade. So this is a detail of what I told you during the introduction, so the extra-grade parts of the abutment. As you can understand, this extra-grade portion have to be positioned in the same direction of the divergency of the implant. In this case, we don't have very important divergency, but for sure, the divergency is in the frontal portion. So as you can see in the picture, the extra-grade portion of the abutment is positioned in the frontal part. After that, phonetic polishing of the connection, because it's very, very important, the polishing of the structure, not only in the parts that you can see, but most of all in the part that you can't see. So the part that it's in contact with your soft tissue. Because if you don't have a perfect polish of these parts, you can't avoid problems related with the hygiene of your patients. After that, we go with the end of the rehabilitation, so the acrylic and polishing and characterization. Those is a structure made by acrylic with a composite characterized tooth. And at the end, the day of the delivery, the positioning of the seeger. And as you can see in the picture on the right, the interrupted part of the seeger is in the same position of the extra grade. Okay? This is the final results. And this is the final check of the rehabilitation. As you can see in the particular, different brand of implant, same kind of prosthetic connection. So very important advantages in the organization of the practice. Final result, check of the possibility of to give our patient home hygiene. And this is the first clinical cases. Sometimes we need to go in the direction of immediate loading, because maybe this is the question of the patient, okay? The desire of the patient. This is a case of a young man, really enemy of the brush when came to my office, but the desire was don't pass from removable denture, never pass from removable denture. So for sure, we have to go in the direction of immediate loading. What we have done is the waxing, and from this waxing, a surgical template that is just a duplicate of the waxing. Those surgical templates for us will be a customized impatient tray and a guide for the surgery. The project of the surgery was to take out all the hopeless teeth and to put 6 implants. And at the end of the surgery, use the OT equator abutment as a straight multi-unit abutment, take the impression of those abutment and go in a few hours with the provisional rehabilitation. Now we will see a little video, short video of the surgery. It doesn't matter about the surgery, because surgery is the same that you usually do with your kind of implant or with the use of plastic. Doesn't change much. The only thing that is important in the video is as you can see, after this check for the first line and remember the imaging doesn't fit very, very well because the project was to do both the surgery at the same time, upper and lower jaw. So during the waxing, we changed some line of the rehabilitation, and nowadays, the day of the upper jaw surgery, the template doesn't fit perfectly with the lower jaw. Yeah?
Puoi togliere il volume della musica a 0.
Ok.
Ecco. Perfetto. Non sentivo la tua voce. A zero, a zero.
Così la senti?
Ecco, così va bene.
Così la senti?
No, no, tira via musica.
Solo che se tiro via la musica, tu mi senti?
No, sentiamo te.
Adesso mi stai sentendo?
Sì, tutto a posto.
Ok, allora tolgo.
Toglila.
Ok, no, perché quando tolgo la musica non sento te parlare, per cui adesso vado avanti. Okay.
Toglila.
Okay, so without music, it's a little bit boring, but maybe you can listen better my voice. Okay, so the implant placing using the usual rule for immediate loading. So more than 35 Newton of insertion force for your implant. In this case, 5 implant in natural bone and one implant with sinus lift, crystal sinus lift. And this is the end of the surgery and the very important moment of the use of the articulator. As you can see, it's very fast and very useful to put the articulator in this situation. Using micromotor, you can go in all the portion of the mouth, also distal part of the mouth, and you can perfectly check the force of insertion. Those kind of abutments are inserted at 25 Newton, really too much respect usual multi-unit abutment because of the diameter of the screw. Okay, so you can use it at 25 Newton, and multi-unit abutment usually are used at 10, 12 Newton at least. Okay. After the suture, we go for the impression. On this case, we take 2 impressions. First impression with snap-on transfer, as you can see, with commercial impression tray. And those impression is to have the position of the implant and the profile of the gum. After that, a second impression using transfer screw transfer, and using the duplicate of the waxing up that give us a check of the position of the implant and give us also all the information about the relationship between upper and lower jaw. Okay, for sure you can use only the second kind of impression, those if you block all the implant. So in that way, just one impression, you have the position of all the implant, the inter-arch relationship, but you don't have the profile of the gum. In my opinion, is more important position of implant respect and the inter-arch relationship respect the gum profile, because gum profile change. The day after the surgery, it change. The day in which you remove the suture, it change because of the solid swallowing. So for me, it's most important position of the implant and inter-arch relationship. We have seen all the steps for the realization of the provisional, and I will explain you better those steps when we will see the imaging of the lower jaw. So this is the final results. In the lower jaw, we go after maybe 1 month, respect the upper jaw, and the project is put 4 implant and take out the hopeless teeth. So, not video. This is the imaging of the image of the surgery, of mandibular surgery, and this is the positioning of the articulator, as you can see at the end of the surgery before the suturing. In the lower jaw, we went only with 1 impression, with our duplicate of the waxing of the starting wax. So in that way, we have position of implant and also inter-arch relationship. In this case, we went with the single model technique. So we already have the articulator, in which my technician have done the wax up, and we use the same articulator, adapting this model with the rotating of the gypsum. So on that way, we have our articulator, and we go for the realization of the provisional. Those that you see in the picture is the reinforced wire, because in this systematic, you have abutment dedicated for provisional rehabilitation, in which you can insert this titanium reinforced wire. It's very easy to use, it's very fast, it's very economical. It goes inside the walls, and after that, it's inside the acrylic. And that way, very fast and very easy to use to have a reinforced provisional, not only acrylic, but with a titanium wire reinforced. And this is the final results, okay? Sometimes you can also go with guided surgery. So immediate loading in guided surgery. You know that guided surgery have some mistake, but for sure, of course, have a lot of advantages. In a case of this, you just have to project your rehabilitation to choose the number and the position of the implant. In this case, very easy case, 6 implants for a lower jaw fixed rehabilitation. You can see in the picture in the lower portion of the slide that on that way you can also check the depth, the thickness of the gum. So you can choose the correct height of your attachment. Because before respect the surgery, you have notice of the thickness of the gum. On that way, the day of the surgery, you are ready with everything you need. When you go in freehand surgery, you are not sure the height of the equator that you need. So maybe you need more different height of the same diameter of the equator. But in my opinion, I always use the shorter one. And I will explain you why in last clinical case. But if you want to be sure about the correct height of the equator in guided surgery, you can be sure about that. So the day of the surgery, you have your surgical template, you have your provisional already done, you have your OT equator of the correct height, and you have your extra grade abutment. The red things that you see in the right part of the picture is a check for the positioning of the abutment extra grade. In this case, we have all straight abutment because it's guided surgery. But if in guided surgery, you have to avoid some anatomical structure, maybe you have to put your implant in a tilted way. So it's very important the positioning of the extra grade abutment in the correct side. So this is a solution to avoid mistake in the positioning of the extra grade during the fixing of the provisional. On that way, you can have the advantages of guided surgery. So first advantages is surgery benefit related with flapless surgery. So no flap, no blooding, no swelling, no pain, and short time of the surgery. At the end of the surgery, you can use your OT equator, as I told you before, with the micromotor to check the Newton insertion force. And as I told you before, you can have the perfect height of your abutment. As you can see, in this case, I have chosen the shorter one, so 0.5 millimeter, because in fixed rehabilitation, I always use a shorter one. So you have your provisional already done. You just have to cement your extra grade abutment inside this provisional, something that need maybe 20 minutes, and at the end of that, you have your provisional. So a little bit more time for the project of the surgery, but a really safe surgery, and a very easy and good result for the provisional. Last case that I want to discuss with you is the case of fixed prosthesis on no implant. To face a no implant, luckily, is not a common situation, but occasionally it happens because of the worldwide diffusion of implant, and because of the very important number of implant brands we have today on the market. If the dentist, the surgeon was good, and the patient was careful in the maintenance of the implant, it occurred that a fixture survived the prosthesis. So sometimes you can have the necessity to rehabilitate some implant that you have not put in the patient, and sometimes patients have lost the specific of the implant himself. This is the case of a young patient that came to my office with the teeth in the pocket. And the first things that capture my attention is the presence of only one screw, and that the fill of one of the crown is correct. So it can occur only in one occasion, the fracture of the screw inside the implant. So in this case, we have two problems. First problem is to take out the broken screw from the implant. Second problem is implant unknown. We don't know what kind of brand we have to manage. For the extraction of the screw, we have a device that it's called broken screw extractor kit, and I will show you how to use. For the problem of the implant unknown, RAIN 83 have a solution. For a long time today, we have the possibility to have customized abutment from RAIN 83 for the retention of removable denture. So in my career, in a lot of situations, I have faced implant unknown that need new connector for the retention, because after some years maybe they have lost retention, or maybe because it's not my preferred kind of attachment. So in a lot of situations I've used this solution. But today we can also have customized OT equator. So if we can have customized OT equator, we can of course have fixed prosthesis. What we have to do, we just have to send to the factory RAIN 83 something that was screwed on the head of the implant. In this case, an abutment, but if you don't have an abutment, it's enough also a cover screw or a healing screw, something that was screwed on the head of the implant. On that way, in the factory can read the connection and the screw, and they can customize for you an equator that perfectly fit with your unknown implant. If you are unlucky and you don't have nothing that was screwed on the head of the implant, you can take an impression, precision impression of the implant. It's very important in the impression, the screw and the implant connection. On that way, in the factory RAIN 83, they can, of course, manage for you the realization of a customized abutment. Okay? So, first of all, the extraction of the broken screw. The broken screw extractor kit is a kit with a drill that help you in the removing of the broken parts of the screw. To work very well, it needs a centric device that must fit perfectly with the head of the implant. So Also, in this case, you need to know what implant it is. If you broke a screw inside your preferred brand of implant, you just have to tell, I broke a screw inside implant of this brand, and they send you the correct broken screw extractor kit. In a case like this, we go in the same way to have the customized equator. So we send something that we have screwed on the implant or an impression of the implant, and then RAIN 83 give you back the broken screw extractor kit. So first of all, the remotion of the broken screw, and after that we have our implant free, in which we can screw our customized abutment. So from now we can start for the rehabilitation, as I showed you before, of another bridge, with another bridge. Things that I haven't told you is that OTobridge is not dedicated only to the full arch rehabilitation. You can also go with short rehabilitation like this. For sure, of course, you can't go with the single implant rehabilitation because you don't have anti-rotation. So at minimum, you need 2 implants like a case, in a case like this, okay? For the realization of the provisional, we choose the analogic impression. So with a customized impression tray that we have done before, the impression with screw retained transfer, and the realization of the master model with analog dedicated with this systematic. The realization of the provisional have done in CAD/CAM way, so before the project of the provisional, and after that the milling of the acrylic provisional that are cemented on this extra grade abutment. For the provisional use of the Seeger, we prefer the provisional Seeger. So we have 2 different kind of Seeger, the pink one and the white one. The white one is for the final restoration. The pink one is for the temporary restoration because is less stronger. So it's easier to be removed during the practice in your office for the aesthetic trying or for the trying of zirconia and everything. So the use is the same, the positioning is the same, the color is different because different is how stronger it is. The delivery of the provisional in a case of this is a choice that I've done. But of course, in a case in which you have a heated implant, so osteo-integrated implant, maybe you don't need provisional. But I prefer, before, build a provisional for different reasons. The first reason is that I have to do new crown also in the 4.5 element, natural element. So I have to wait the healing of the gum, and for that reason, during this time, I prefer to give to the patients something to chew. The second reason is that with the provisional, I can have good healing of the gum and good profile, better aesthetic results. For the final restoration, we decide to go all in a digital way. So scanning, intraoral scanning of the OT equator using dedicated scan abutment dedicated to this systematic. The file of this intraoral scan go to laboratory, and first of all, we print the model. Because in a case like this, we prefer work to printed model, not without model. And this is the printed template with the dedicated analog for analogic way of work. First things that we have done is cheap aluminum test. On that way, we have something to check the precision of our impression. And at the same time, we have something that we can try in mouth to check the occlusal contact to check the interact relationship. This is not our daily practice, of course, but in a case like this, with a cheap solution of aluminum test, we can have we can solve two problems. So the check of the precision of the impression and the check of the occlusal contact. After the adjustment of the occlusal contact, we come back in digital world, and the first things is the saving of the morphology of our adapted aluminum test, and the final project with some correction of the shape. And now with in subtraction technique, the zirconia project. This is the zirconia structure that, as you can see, work up the same way of the provisional. So it's cemented on extra grade abutment. And as you can see, different kind of seager, white seager for final rehabilitation. This is the testing mouth of the raw ceramics, and after that, the finalization. So polishing of the ceramics and the positioning of the seager. As you can see in this picture, the position of the extra grade is randomized. We didn't need any position of the extra grade because those implant was straight, was parallel. But of course, if they wasn't parallel, we can manage the correction of the divergence using correct position of the extra grade. Okay, so before screw the final rehabilitation, what I want to discuss with you is the conditioning of the tissue that I had with the using of the provisional. And this is what I desire in fixed rehabilitation. Okay, in a case like this, of course, I don't have a very important aesthetical necessity because it's posterior teeth. But you have to imagine the same things in frontal zone. I like very much to have the abutment inside the tunnel. On that way, you can manage the emergency of your crown, and you can have better aesthetic results. That's why I've told you before that we use the same attachment for removable and fixed solution. But for removable solution, I need to have this abutment outside the gum. In fixed solution, I prefer to have the same abutment inside the gum. So the day of the delivery, this is the final results with the correct aspect of papilla and of soft tissue, and I think good aesthetic results. This is the RX check. And as you can see, it was an easy case, only 2 implants, but with some mistake, difficult to manage without these systematics. Because first of all, on that way, it was easy to take out the broken fragment of the screw, and very, very important, we can manage the fixed rehabilitation of unknown implant. And I really don't know another way to do that. This is the only way that I know to build fixed rehabilitation on unknown implant. So maybe, in my opinion, this is enough. This is enough to use this solution for fixed rehabilitation. Okay, now we are at the end of the lecture. The take-home message that I want to leave to you is the advantages of use one kind of attachment for removable and fixed prosthesis. Use this kind of attachment with different brand of implant. Use this kind of attachment also in unknown implant. You can do a lot of things, and in my opinion, you will love this kind of attachment using it. using it, for sure you can check your personal benefit, and you can really better understand what I want to tell you. Now with that, I finished my lecture, and I'm here for your question. And I hope that you enjoy and that it was a fruitful hour. And now I wait indication from the host for what we have to do now. Thank you very much.